Thank you guys. There's some great case presentations. I'm very excited to introduce one of the leaders of the team of APPs that takes care of so many of these patients, Elissa Castor. She's going to be doing a talk on comprehensive care and support for patients with new and lifelong aortic disease.
Thanks, Eric. The question I'd like to pose today is how do we provide comprehensive care and support for the patient with new aortic disease? So the answer to this, and we've heard this echoed through all of these talks throughout the day today, is early referral to early referral to a multidisciplinary aortic center that addresses the physical, it didn't come up here. There it is. Early referral to a multidisciplinary aortic center that addresses the physical, mental, and emotional implications of aortic disease. The first recommendation of the top 10 messages that were selected from the 2022 AHA-ACC guidelines for the diagnosis and management of aortic disease emphasizes the importance of a multidisciplinary approach due to quote-unquote enhanced outcomes. At UPMC, we're very proud of the network of providers at our aortic center that collaborate to provide just this for our patients. So our multidisciplinary approach at our aortic center includes first, an individualized plan of care and early intervention by aortic surgeons. According to IRAD data, which Dr. Eagle already touched on, 59.2% of aortic dissections occur in patients with aortas that are less than 5.5 centimeters, so they're below surgical threshold. The ACC-AHA guidelines that just came out have affirmed this trend towards earlier intervention and have lowered those thresholds by a half centimeter. And they've also emphasized the importance of having a more individualized approach to patient surgical planning based on risk factors. So these surgical thresholds should not be a one-size-fits-all approach, as we've heard multiple times today. At our center, we tailor our surgical plans to our patients by considering body size. So in clinic, we calculate aortic indices. We consider morphology of the aneurysm. We also take a detailed family history. We consider genetic diagnoses and lifestyle. For appropriate patients, we refer for genetic testing and counseling with the ACHD. The 2022 guidelines also recommend more aggressive testing of our patients who suffer dissections and all of their first-degree relatives. Next, surveillance with an aortic center provides accurate imaging and reading. So rather than some of the less accurate modalities that we often see performed in the community setting, so echocardiograms, unenhanced CT scans, non-gated CT scans, all CT scans performed in our clinic are performed with IV dye. They're EKG gated, meaning that they're performed during systole. They're read by cardiac radiologists, so the methodology for measurements are consistent, so we're always doing sinus to sinus, inner edge to inner edge. This allows us to compare apples to apples year over year as we surveil these patients. Lastly, we refer to other subspecialists as needed, including vascular surgery, ophthalmology, orthopedics, maternal fetal medicine, etc. So once patients are referred to our aortic center, we could simply outline a surveillance plan, treat the blood pressure, and call it a day. But to genuinely care and support these patients, we can't focus on the physical treatment alone, as we've heard. It's important that as practitioners, we consider both the mental and emotional implications of this diagnosis as well. So when patients come to our clinic, they're typically diagnosed one of two ways, either incidental findings, so they show up in the ER with shortness of breath, they get a PE protocol CT scan and have this aortic condition that's discovered, or they have a lung cancer screening that shows some type of aortopathy. Number two, they may present traumatically, so with aortic dissection, rupture, or some other catastrophe. In both scenarios, we typically encounter the new aortic patient as anxious, fearful, guarded. Patients who come with aortic aneurysms to our clinic are often overly restricting themselves. We've even seen patients come who have quit their jobs, who've completely halted exercise because they feel like they have a ticking time bomb in their chest. As the title of this very symposium describes, aortic disease is a lifelong diagnosis, and when you pair that with the diagnosis of a genetic condition, it really carries an additional emotional and psychological burden. So therefore, we have to approach these patients with a threefold goal of addressing the physical, mental, and emotional implications. First is the physical treatment plan. So in our first encounter, we start with outlining a clear surgical or surveillance plan. We do this through shared patient-provider decision-making, which we highly value. So this is that individualized surgical plan approach. So just to give you a couple of examples of what this might look like in real life, and these are all real patients that we've had over the last year or so. For example, we may offer earlier intervention for a patient who's a 59-year-old male with a 4.8 centimeter ascending aortic aneurysm and family history of aortic dissection. So for him, our traditional recommended threshold for surgery would be 5.0 centimeters. So it would be quite reasonable to continue to surveil him. However, he was crippled by anxiety because he had a twin brother who had died earlier that year from an aortic dissection. So we elected to operate earlier for this patient. Another example is a 45-year-old male with a 5.2 centimeter ascending aortic aneurysm. He had no other risk factors, no family history. So for him, a recommended threshold would have been traditionally 5.5 centimeters. But he was a competitive weightlifter and bodybuilder and felt like his quality of life had been significantly limited. So again, we offered an earlier surgical plan for him. Additionally, we've offered strategically timed and prophylactic aortic surgery in collaboration with maternal fetal medicine for aortic patients who are wanting to conceive. Next, blood pressure management is one of the most important parts of our care plan, which we've talked about multiple times today. In our clinic, we aim for a goal systolic blood pressure for most of our patients under 130. We make sure that patients have a blood pressure cuff at home, they know how to use it. We encourage them to log their pressures and call us if they're consistently running over that mark of 130, 135, so that we can titrate their medications. Next, we address modifiable risk factors. So this is encouraging smoking cessation, avoidance of illicit drugs that can induce dissection, and we encourage patients to remain active and exercise. We address activity restrictions and all of the real-life questions. So these are the things like, can I ever ride a roller coaster again? And can I still roughhouse with my kids? Can I still use Viagra? And can I go to the gym and continue to lift weights? These are the kinds of questions that are important for us to address because these are the anxieties that patients face when they have this new diagnosis. And then lastly, as mentioned previously, we refer as needed to subspecialists. Next is the mental approach to the aortic patient, and this is through patient education. So John, who's listed here, is a patient of the UPMC Aortic Clinic. He was recently diagnosed with Marfan syndrome and underwent an elective aortic root ascending and hemiarch replacement. He did very well clinically, and he served as a patient panelist this morning for our patient breakout session. And as John and I were communicating over the past 3 weeks in preparation for today, he said to me, as cliche as it sounds, knowledge is power. This morning, he really emphasized how understanding his disease process empowers him to continue living life despite being diagnosed with Marfan syndrome. So as clinicians, it's very easy for us to focus on the disease process and tangible treatment options and forget how powerful it is to equip and educate our patients to really understand their own condition. So in our clinics, we start with education of pathology. I'm really proud of our APP team. Both the APPs and the surgeons really sit down and spend time with these patients. We pull up their CT scans. You can see the 3D reconstruction image on the right over there. We pull these up on the computers in the exam room so that we can show the patients their pathology, educate them on their diagnosis. They really, truly appreciate this. Second, we give them an aortic emergency card. So at our aortic center, we've come up with a wallet card that patients can keep with them. We tell patients that if they ever go to the ER with chest pain, back pain, belly pain, any other neurovascular symptoms, that they should give that card to their emergency room provider. That indicates that they have an aortic condition, so it helps to expedite appropriate testing, and it also has a direct line to our on-call aortic center so that we can expedite rapid transfer if needed. Lastly, we really just try to help patients wrap their mind around the lifelong nature of this diagnosis and kind of help them to process that this is going to be a part of the rest of their life. Last is the emotional and psychological care of the aortic patient. In our aortic clinic, we really try to take a primary care approach to these patients. We try to reassure them at that first visit and try to remove the angst associated with that word aneurysm, which is very real. Many of our patients have followed in the UPMC Center for Thoracic Aortic Disease for well over a decade. So we really get to know these patients as we see them year over year. We know their names, we know their parents, we know their spouses. We've walked through surgery with them and recovery, and sometimes multiple subsequent surgeries. They call us often for reassurance and advice, and in many ways we serve as their most trusted and primary providers. As we mentioned, familial aortopathy that could have a genetic component is a huge emotional burden for a family. One of our other panelists this morning explained that the hardest part of his diagnosis of Marfan syndrome was finding out that he had passed it on to one of his daughters. So at UPMC, patients are counseled as a family through the genetic testing process, and when indicated, all first-degree relatives are tested. As we saw at this morning's breakout session as well, patient connections over a mutual diagnosis are empowering and encouraging. The quote on this slide here is from Rachel. She's also an aortic center patient here at UPMC. Rachel suffered a hyperacute type A dissection last year. She underwent emergency surgery at UPMC and subsequently was diagnosed with the ACHD as having EDS classical type 2. In regard to participating in this morning's patient session, she said to me, "This is my main coping mechanism when it comes to loss, tragedy, or struggling for meaning. If I can help someone as a result of my misfortune, then it wasn't for nothing." So as providers, we really have, it's really important for us to have an awareness of the resources that are out there for our patients so that they can find the same kind of community support and meaning. The Marfan Foundation website, which I've spent a lot of time on over the last 6 months, is a really excellent resource for our patients. It has abundant amounts of information, including disease information, patient stories and testimonials, support groups, and community events. We've been honored at UPMC to partner with the Marfan Foundation for this event and are grateful for the resource they are to our patients. That's all. Thank you so much.